So, for this afternoon, thank you for inviting us to the meeting of the Centers for Health Development for the orientation dito sa National Policy of Prevention of Blindness. So, my part is presenting the Philippine IDC study and the National Vision Screening Program. Teka, sinubukan ko lang ito. Yan. Okay. Now, I'm from the Philippine Eye Research Institute. It's an institute established by Republic Act 4593 noong June 1965. So, kasing edad ko. But it's the oldest institute of National Institutes of Health under the University of the Philippines. So, in 2018, the DOH funded the Philippine Eye Disease Study. And previously, also funded by the DOH because of our Vision 2020 program. We've been, the Philippine Eye Research Institute have been looking into the prevalence of blindness in the country. So the first survey of blindness was in 1987, which showed a 1.0% prevalence of bilateral blind. When we say bilateral blind, a person cannot count yung fingers. Yung Snellen kasi natin, the big E is like the size of our finger. So if you're using the Snellen chart or using your fingers for that big E, if a patient cannot count at 3 meters away, they're already considered blind. No? So if both eyes are like that, or worse, yung isa, the best eye cannot cannot count at 3 meters, considered na siya bilateral blind. In 1995, the prevalence was reduced to 0.7%, and in 2002, 0.58. Now, the WHO international guidelines is for countries to have bilateral blindness at a prevalence of less than 0.5. So, kaya during this time, there was the Prevention of Blindness program by the Department of Health. So in a way, it was the intervention was working kasi it has been decreasing. However, because of the increasing population, unfortunately, yung prevalence ng bilateral blind sa 87, 95, and 202, parehong 500,000. Now, for the fourth survey of blindness, during this time, there were more intensive implementation of the mga programs ng DOH and the increasing the capacity of the regional hospitals for eye care, no? So we're expecting the prevalence to be lower, no? So the first three national blindness, it was really, we just look at the blind people, focused on that. But for the fourth survey of blindness, we were working on the Philippine IDC study. So although the primary, the goal was to check the prevalence of blindness and visual impairment, we also looked at the specific diseases. So unlike before we were just carrying the ophthalmoscope, tapos Snellen chart, ito talagang we brought equipments already to make sure that our diagnosis would be accurate, no? So, nag-set up tayo ng 6 stations for each of the randomly selected barangay. Nag-set up kami nung mga stations, no, to examine the patient, no. So, buti my team from the Philippine Eye Research Institute, our staff have been doing this for several decades na. So it was easy to work on this, no? Despite the difficulty with this IDC study compared to the survey of blindness. So registration, we look at of course history taking. We got the personal data, socioeconomic data, but this, when it was entered into the computer, it was automatically anonymized, no? And the vital signs were taken, the color vision test, the height, weight. We even included waist to hip ratio, blood pressure, temperature. All these, kasi even the blood glucose level. to see other potential factors for blindness. And we brought in automated refraction. So thank you, Department of Health, for providing then the logistics, no, for us to be able to rent these equipments, no. Refraction keratometry. Visual acuity, I know, although most of our clinics are still using Snellen chart, is not really accurate for studies or like when you create policies. So we use Leia numbers or Leia symbols for children, eager chart, and we looked at the best corrected vision. So no, when patients have eyeglasses, kasi very common yung error of refraction. If they can see, so they're not considered blind because that's their best corrected vision. Now, when we looked at the WHO category for blindness, when it's 3, no, category 3, 4, and 5, this is when we say blind, WHO blind, they cannot count fingers less at 3 meters. Now, but legally, when you say blind, dito tayo sa moderate visual impair, dito sa severe, no? They can only see actually in between the big E, no, or 660 or 2200. So nandito sa visual impairment. Now, driving, when you say you're allowing a person to drive, no, that's 20/40. So when you say with visual impairment, they cannot read that, no. In fact, they can, if you kung mas familiar kayo sa Snellen chart, they can only read the first 3 lines of the Snellen chart. So if they can only read that, they're considered visually impaired because you need to read the 4th, 5th to be more functional in society. We also we brought in optical coherence tomography, no, where we can really see the retina, the optic nerve, anterior chamber angle. So parang ganito siya, no? It's like infrared, then we could see actually a cross-section of the eye. Yun naman ang advantage sa mata, no? Because it's like the cornea is clear, so we're able to get a cross-section of the eye. Of course, we have the complete ophthalmic evaluation, using slit lamp, we dilate if needed, and we got the pressure, the tonometry, no? And then we recorded it. So ginawa namin, we use a customized software so that we were not parang getting the chart, no, from each station to the other. We just log into the patient. May barcode. Parang we look at the name of the patient, then we are able to input the data per station. So medyo na-elevate natin konti itong survey para it's more computerized, and then we're able to get the data in the future, no? Parang, I mean, as we go on, no? And of course, those with the eye problems, we're able to refer them to the nearest tertiary hospital with an adequate eye care facility for referral. Now, with the results, when we looked at the participants, no, we have an 86% response rate, was quite good, almost 50-50 ratio, and average members per household is 4.51. Like the rest of the country, the mean age is in the 30s, no? 1/3 are the pediatric age group, 1/3 40 and above, no? So significant kasi 40 and above, that's when they start wearing, they're having presbyopia. So when we looked at it, the prevalence of bilateral visual impairment, no, is 1.98%. So around, during that time, around 2 million na yung population natin na involved. And when we look at it, true enough, the bilateral blindness, di ba yung third survey of blindness, 0.58 202. So medyo natagalan, no, ang jump kasi natagalan siya, but then we were able to create a complete a better survey. Mababa na siya at 0.19. However, if you look at it, mas accurate ngayon yung determination of bilateral visual impairment, kaya mukhang mataas pa rin siya. It's possible na the previous data were not really that accurate, no, the last 3, because we were just focusing on the bilateral on the blindness. Then, of course, the linear trend in the visual impairment across age group, no? Pag above 60, medyo tumataas na talaga yung visual impairment because of cataract. Now, when you look at the prevalence of visual impairment, like we mentioned, it's 1.98%. What are the major causes of visual impairment? It's still cataract, no, for Philippines. So around 1 million Filipinos have cataract. But since we were looking at what's the required which group would require surgery. Kasi if you notice, no, when these patients are seen by the ophthalmologist in the eye clinic, no, if the visual if they are if they have visual if they are visually impaired, most likely surgery is offered. Unfortunately, the capacity of the Philippines to operate this cataract is only around 100 to 150,000 per year. So that's why we are parang saying, I mean, if you look at the public health perspective for this, that it's best if we prioritize operating those patients who should have the surgery because it has impaired their day-to-day activities. So around 300,000 ito. How do we communicate this? So we tell the patients na, especially like ngayon pandemic, they're really asking, kailangan ko na ba operahan? May katarata ako. We say if there's a Snellen chart, you can only see the big E or you cannot see the big E, malamang you are a good candidate na for surgery, especially if you have vaccination. Now, the second cause of visual impairment is uncorrected error of refraction. So, many of our population, around almost 398,000, they just need actually eyeglasses for them to see better, no? And then we saw that this was followed by glaucoma, around 300,000 Filipinos causing visual impairment, no? And maculopathy and DM retinopathy, around 200,000 Filipinos. And however, the nice thing with this new study, the 2018 Philippine eye disease study, we were able to look at those patients who are actually normal, no? They're not complaining that they could not see kasi little or no visual impairment, but because we checked on them, no? Around 3.4 million of error of refraction, uncorrected error of refraction. And we have a significant number of Filipinos with glaucoma, around 700,000 and 600,000 with DM retinopathy, no? So these are patients of diabetes for quite some time, and then they develop retinopathy. Now, it is interesting when we look at those with diabetes, no? The prevalence of diabetes is 3.1% for the population, but in most studies, if you look at when they present diabetes, they look at the age 20 to 79, no? What's the prevalence? 6.5, no? Of course, the WHO says it's a crisis if it's 8%. So we're around 6.5%, no? Pero madami na rin yun. And of course, although but we know this, but for some might be a surprise, no? Among those with diabetes, actually 40% of these patients, kasi we screen, we get the blood sugar pag 40 and above. They don't know that they have diabetes. So only 6% know that they have. And among these, overall, 9.7% have retinopathy already. So even if those who didn't even know na may diabetes sila, pwedeng may retinopathy na sila. So that's why the screening is really important. And I just want to show na part of the study, kasi nga we're looking at eye diseases na rin, no? So we look also at error of refraction in the Philippines among children, no? The prevalence in kindergarten is 8.9%, no? So around 10%. High school is 16%. So increasing myopia as they grow older, no? And 80% of these with EOR have myopia, nearsightedness. And actually worldwide, there's an increasing prevalence of myopia, and especially in Singapore, where there's really a very almost 90%, more than 90% prevalence of myopia. The complications when they reach high myopia would be the maculopathy and also glaucoma. And fortunately, over the last 5 years, no, there's been studies na although it's largely genetic, but a certain percentage around 40 to 60% could be environmental, no? So it has been shown that outdoor exposure can reduce myopia progression. That's why we had in several, as an output of this Philippine IDC study. So when the WHO had this program about myopia and the intervention, we were able to collaborate with DOH and especially DepEd that to increase outdoor exposure. So apparently in the curriculum of the DepEd, meron na silang 1 hour where they have outdoor, but they committed, hopefully they'll add another hour. What's really recommended is 3 hours per day of outdoor exposure. It's not really direct sun. As long as you are exposed to the strong light from outdoors, even pag nasa loob ka, no, like, or may cover, or like, of course, when they play outside, it already reduces myopia. No wonder when we screen patients, no, in the provinces, they really have less myopia compared dito sa urban, no, because they have less outdoor exposure. So even in Singapore, they wear this band na instead of yung sa atin walk, they monitor our walk. Sa kanila, minomonitor yung outdoor exposure ng bata to reach the 15 hours per week. Now, so with that, no, so that's the Philippine IDC study, and now knowing this prevalence of air refraction, but this was over the last 6 years. We have been working on the vision screening program. So we actually looked at we collaborated this with the DepEd and the DOH. Now, in terms of what could be a public a program that can be integrated in public policy, and we look at the burden of evidence, no, in terms of the different conditions, no, of the eye, that where it would be good if we could intervene, no, and in the case of amblyopia or lazy eye and error of refraction, the burden of evidence is there. And then we looked at this is really the process when we recommend for health policies, no, public policies. We look at the test accuracy. Is it, so maraming meron, tapos may pang-test naman tayong mabilis lang. And then when you treat, it's effective. So it's worth doing it as in a public health, no? May typo lang, cost effectiveness. It is, there's no local studies, but it's cost effective. And we look at the recommendation of the others. But we're actually, in other countries kasi they really recommend screening. But they have it already in their healthcare system. Sa atin kasi, ang recommendations kasi around 3 to 4 years old. So, but in the Philippines kasi, wala pa sila sa school. Although we have a program in our, hindi pa ganun ka-develop yung eye program. So that's why it was worth it working on it as a health policy, as a legislation. So with the recommendation, we did some legislation. And then, fortunately, after 6 years, the National Vision Screening Program was signed into law by our President. July 31, 2019, Republic Act 11358, no? And essentially, what it does is that we have this vision screening kit, no? It's this Leia symbols. Meron din numbers kasi if you want to screen the older age group, but under the law, it's a mandatory screening for kindergarten. Why kindergarten? Kasi they're like 5 to 6 years of age, and the intervention needed to treat amblyopia or error of refraction, it should be before 7. So hindi rin talaga to pwede before. Kasi yung kinder natin, grade 1 natin, wala pang kinder before, was already 7 years old, no? So it's just the right time, no? And it comes with all the simple tools, no, for the screening to be done by the teacher. So we have this in the kit, no, and when we train, no, trainers who will train the teachers or the school nurse So we have the setup, no? Parang especially yun, the screener, 10 feet, kaya there's a string. Kasi in the field, when you do this, minsan, pag hindi ganun ka-specific yung instruction, no? I've seen it no, when we train, tas hindi ganun ka-specific yung instruction. Kahit meron ka ng string, parang hindi naman nila sinistretch yung string. So kapag basta, ano lang, so that's why we're very specific when we train and what to do, and then the room, what the chairs, and then we practice. No, we practice the patient with both eyes open. Then before we cover, tapos yun lang. It's very simple because it's there's just one. This is for training, and this is for training. Sorry, this is for training. So tinitrain lang natin that they have to point to. These are universal symbols, so it's easy to train. So, like ito, parang apple sa US, sa atin naman puso. So, parang ganon. Di ba yung mga bata, minsan ang rectangle, square, pare-pareho sa kanila, no? So, those are the things. And these are the optotypes. So, one eye at a time, if they can answer 3, it's a pass-fail system. If they can answer 3, pasado na sila. Tapos if they then the other eye, no? Pero we are actually, ang rating natin sa school, FR or NFR. Kasi they might think it's an exam, no? FR means front row. Tapos that means if they fail, they're not able to identify, kailangan sila they have to be placed in the front row. And then if they but if they're able to identify, then doon siya sa likod, no? Actually, I want to emphasize na when we do this, crucial actually yung chart. Of course, the lighting, but more of the chart because we were looking into paano kung i-xerox na lang natin to, no? But then when we, at that level, maraming mga false positive. Ibig sabihin, hindi nila nababasa, but only because the contrast sensitivity, the contrast of the letters and the white part of the chart is not very good. Now, we wanted to control this para it's very specific yung ma-identify because we're hoping in the future that the DOH, through the DOH and the PhilHealth, that we will be able to provide, no, services to these patients, to the kids who will not be able, who have error of refraction. Now, so far, when we looked at the, actually before na-sign into law, we're very happy that some of the DOH centers in other regions, they have been adopting this, no? Yung vision screening. So, kaya medyo madami na tayo. I mean, although it's still mga around less than 5% implementation, pero at least several areas na implement. And then, in fact, when we looked at like in Cavite, so that's why we're able also to get the prevalence, no, of those who would fail in the test. This is a teacher, no? Parang I'll show you lang parang ano niya, parang experience niya with the vision screening.
Alam ka na, ang mga guro ang magkata ng vision screening kasi yung mga bata, sanay na sila sa amin. Pag makakita kasi ng nurse or baka matatapos sila sabihin, injection yan, injection ito, ganyan. Kami yung nakakaalam pag ang mga bata ay may pangangailangan. So, pwede namin yung gamitin. Kasi alam namin kasi kami yung nakakilala sa mga bata. Kasi hindi namin alam na pwede pala kaming mag-screen. Kasi ang alam namin, yung visual screening ay ginagawa lamang ng mga doctor sa mata. Nung naka-attend kami ng training, hindi namin alam na pwede pala. Nakakatulong din kami. Sabihan namin yung mga magulang nila na ito, ganito, ganyan, pwede bang mapatest or pag mayroong available na doktor sa isang division or sa paaralan na pwede makatingin. So, mahalaga po kasi nakakatulong po as a teacher. Actually, madali lang. Madali lang yung, smooth lang yung training namin. Maganda yung feedback ng mga trainers namin. Tapos, palagay ko, madali lang makuha ng bata ang process or procedure kung i-explain muna natin kung ano yung gagawin. In a play-based way, sabihin mo na sinong makakita dito o pag hindi, okay lang. So huwag magtakot kasi nandiyan naman si teacher palagi. Tapos para lang kayong naglalaro. Sinong masusunod? O pag hindi niya nakita, hindi niya alam, sabihan mo siya, hindi mo sasabihan na, oh, hindi ka nakakita ng ganito, ganyan. Mas mahalaga po na may NVSP, lalo na po sa remote areas, kasi po hindi nararatingin po sa doctors, lalo-lalo sa OFTA. Kasi po sa amin, limited lang ang mga OFTA namin. How much more na hindi na sila pupunta sa remote. So NVSP, pwede natin, siya ang bridge pa, pwede siya ang access, siya ang bridge from remote to city or sa OFTA, pwede siya ang bridge para malaman ng OFTA na ito, site na ito or itong lugar na ito is meron palang mga bata na pag hindi maagapan na kanila ng mata, pwedeng doon sa malalang sakit. Pag may malinaw na mata ang mga kabataan, nakakaintindi sila lalo sa mga aralin. They are very attentive at saka productive in school. Pag alam nila, tapos hindi nila masyadong nakikita yung aralin, maapektuhan talaga. Ang papel kasi television screening very started, diba? From kindergarten, yun ang first na po natin, focus natin. Kung hindi tayo mag-screen sa kindergarten or sa younger age nila, at pag nasa future na sila, hindi makorek yung tamang vision nila, doon tayo problema. Doon ang problema ang bata. Ma-detect na lang pag hindi na maaga, pag maging permanent. Pwedeng maging hindrance pa yun ng nila, future employment nila. As yun, lumabas yung screening nga yun, isa pala si Marty Sabay. Talagang sino ba kasi pataba siya may sarap kaya po siya sa likod. Kasi siya pa yung nauna natapos at nakapagpa-check ng mga gawain. Napabasa na niya yung
Thank you. Sorry. Okay. So, but during the pandemic, so we couldn't, although we're working on distributing these kits, to different areas of the country, but we tried to develop the online remote vision screening. So there's a trained screener dito actually sa Perry, then there's a remote screen dun sa house, and then to be conducted by the mother, So it's our bridging program which we introduced during the World Sight Day last year. So the good thing with this is that we just share any device pwede. So it's really na ano nga to nung Perry, parang kumbaga naging it's like parang naging na patent or something, but it's a development we did by force of the situation. And since not everyone have Zoom, so pwede siya sa Messenger or Viber. So parang simple lang naman what available in their house, And parang it's really how it's like this, Parang they put whatever screen they have, either cell phone, tablet. Tapos we created a process where they could actually, meron kaming ipipresent because depending on their device, nag-iiba ang size ng hugis ng nung optotypes, So with that optotypes, when we are able to select the right one, so we were able to test na it's accurate na with that size, So nasi-screen din, So we orient the parents, then we monitor their device. and then online, then remote, then we are able to do the testing. So far may mga natitest naman, mukhang okay naman, but soon we will work on a study to really compare, no? And of course, like what was mentioned, the role of the teachers or the nurse in the school is after they screen, they place the students in the front row. And then the DOH comes in when they are referred now to the healthcare system. For now, they are referred lang to the areas where there's an OFTA services, but in the future, hopefully this is taken care of by the Universal Healthcare Program. And may isa pa kaming video if you allow, parang about the remote vision.
Ang pinagkaiba ng online vision screen ay yung proseso ng pag-conduct nito dahil nga restricted pa yung face-to-face classes sa mga kabataan. So una is gumagamit tayo ng online platforms kagaya ng FB Messenger, Viber, and Zoom. So pangalawa is instead na ang teacher ang mag-assist sa mga kabataan, so ang kanilang mga magulang ang siyang mag-assist na kanila.
Sa NVSP, gagamit tayo ng Very Vision Screening Kit. Sa online vision screening naman, gagamit tayo ng smartphone, laptop o tablet. Basta meron siyang speed sharing app. Ang materialis naman ng online vision screening ay improvised kung nagpukumpara dun sa NVSP. Dun sa NVSP, gagamit tayo ng VA chart. Ito. Siya makita nila. Doon naman sa online VS, gagamit tayo ng smartphone, no? Basta meron siyang screen sharing app.
First of all, ina-orient muna sila before i-conduct yung online vision screening. So alam nila yung kahalagahan. Cooperative naman po sila sa online vision screening program natin.
So that was the end of it for the vision screening. Although this will be discussed later on, no, dun sa community program. There are two other programs that the DOH, that the PERI collaborated with DOH, the primary eye care, which hopefully soon can be in the different municipal health officer clinic, no. So it's just a chart where we updated lang the previous one, but we changed it a bit, that we made all the symptoms for the blurring of vision and the trauma. Tapos it's color coded, no, with the red eye. So these are the different diseases. And then at the back of the chart, or two charts, pwedeng two chart, it tells them if they need to treat, what they can immediately treat, what can they see, and that the actions, and when do they refer. This one is just screen and refer, and there are items when they have to refer immediately, and of course the routinary screening, no, yung vision screening for school children, diabetic retinopathy screening, and visual acuity screening for elderly, and of course the retinopathy of screening. So this is our last project the other project that we collaborated with DOH and the WHO. We did parang the DOH worked on the ROP guidelines with the different sectors and of the healthcare providers. And then we came up with this, which is near the international recommendation, that newborns who are less than 32 weeks of age or less than or equal to 1,500 with risk factors determined by pediatrician, like yung mga nagkakasepsis, that they have to be examined 20 days postnatal or before the discharge to screen, because we found out that because majority of all the patients in blind schools are because of the ROP. Yeah. So thank you everyone.